like, I don't like to face these ugly truths about humanity because I'm someone who really doesn't like, I give people the benefit of the doubt to a fault. So, and I always think people are trying their best. Yet I feel like they're less likely to do the test for certain conditions. Like that, it is criminal because like people do pass away because of this and they usually won't know. Like people, so many people, have already died because of this kind of negligence and like them just not doing an adequate job of being diagnosticians.
Occult Awareness, the podcast that shines a light on the shadows of the unseen in our healthcare journeys. And I'm Amy, and each week we explore the twisting paths and diagnosis, challenges that are faced by those conditions that don't show up easily on a standard checkup. From EDS to CCI and beyond, we are here to share real stories and bring the insights of health professionals navigating the intricacies of occult conditions. That's why there is doctors that persuade you not to do certain tests because they feel like, I've done my job already, and you still want to do more.
It does, yeah. It's actually, and it's not even just the individuals that seem to have that attitude, but it's like the whole systems that have that attitude. Frustrating. It's frustrating that they continually like double down behind each other, but it's reminiscent of the way that administration works at like Cornell as well, where I went to vet school, because I noticed that same kind of like very irrational supporting of the last statement that was made on this issue. Even if it seemed that we've had an insightful conversation, like I'll get an email on this issue that's like, well, we feel that when they said this, that this is, and this is like totally different and not related to my medical, it's not related to my medical concerns, but it was related to like me being allowed to take time, but like take a test early in vet school, like whereas they allowed another classmate to and tried to tell me my situation was different. And I shouldn't be allowed to. And that's something I won't let go. Like there's little things that like show you what a place or person really is, who they really are, or like what they will really do when faced with a somewhat challenging decision, which like this was like a weekly quiz that I wanted to miss so that I could go and visit my grandmother who was declining with Alzheimer's. And like, this was like the last visit where she remembered me. So I'm glad that I went. It took a 0, but I had to take a 0. It's the same with, I think, some of these big academic medical institutions where if you do have even very real complaints about blatant abuse and you try to complain about it through the like avenues that are allowed, they're just going to defend themselves and say that they didn't do that or that they did their best because of this and that, or because, I love how they always fall back on the fact that like your condition is so rare or so severe of a presentation that they have never seen, even when I like know other patients that go to that same doctor or same institution, who are just as severe.
This makes you really start wondering, like, why don't we really have this kind of like approach of whoever really complain about certain things, like we can be part of it. Why can't we really be part of it when, we send out the complaint form and request, right, for issues? But they get to define themselves, but we never get to show up for ourselves actually to talk. You know what I mean? Right. Like with the evidence, like there's no way we can only have like 5 lines to write whatever our complaint is, but usually we need a 10.
Yeah. At least, it's there's a lot of different avenues of trying to like keep our stories quiet and silent. And I think that's why this type of podcast and this format of being able to like talk about it from, our bed or whatever, it's very helpful because like those barriers, those little things that, to able-bodied people like would not prevent them from doing a task. They do prevent us from doing a task. And like my point is that's by design, like for example, the state website to get the Department of Health Services. I live in Maryland, so those services, those websites, that website is definitely designed to keep people out or to keep people slow, to keep it so that things are not going through fast, you know. Um
Yeah. I've
like
seen that.
yeah, like that's just, it's not even just that site. It's like any site that relates to trying to give aid from the government
Hmm. Hmm.
is going to be very slow. It, you know, Social Security has hours now, so like you can't even check your Social Security portal at night. Like the website closes. I can't even make this up. Like I freaked out when I noticed this for the first time. Because like it's why I don't always have the best working hours during the day, and so sometimes I do find myself checking things at like weird hours of night. Because that's the only time I can get it done. And like yeah, now you can't do that for Social Security. So just add that to the list of things that have to happen during business hours, you know.
Yeah. Well, it's like this is insane. It's for disability
Mm-hmm.
income, but then they made it like so inaccessible for us
Yep.
to be able to reach
Yeah.
it. Especially, I know a lot of people who like dealing with similar conditions, like having issues with like lights or reading
Yeah.
computers. I have that issue as
Yeah.
well. So it's
Yes, me
difficult
too.
already.
Yeah. Yeah, I have that issue. It like the light thing, like migraines are another issue that like I have probably always had from the age of, you know, little child, but like I saw how like some of the way that I've determined whether or not I think I have something has to do with like how affected I am by it. Like you know how you go in for certain conditions and they think that like because you're not in enough pain it can't be that.
Mm.
um like I think that because migraines, like I saw my mom and like other people who have them like really being debilitated by them, I just thought for my whole life that sorry, I just thought my whole life that I couldn't have migraines, that I didn't have migraines because I'm not that they're just headaches. Like it's because they don't debilitate me, even though yeah, like they were always the kind where like when I go upstairs or like, you know, posturally it would get worse. Like light made it, you know, worse, like all of these things that kind of make more sense now. But
Yeah.
yeah, like it's, I just thought, I thought migraines are something that's like really debilitating. So it can't be what I have.
Or
Yeah.
like, there's a lot of different type of headache now, right?
Yeah. Yeah. Like cluster. It's like, for me, like migraine, yeah, the understanding even around migraines has shifted a lot, like which was starting to happen when I was in college because I studied neuroscience and
Hmm.
psych in college. Like they were starting to realize that migraines are very similar to like seizures. They, in a lot of ways, are small seizures, and that like kind of evolved into like it's kind of, it reminds me of like the autism like re-understanding that's happened
Hmm.
and happening.
Yeah.
Like you know, I have a family member who has like pretty severe autism and like always did from young age, you know, like had epilepsy as well and stuff. Um, and that's what I used to think was autism, right? Like I would never considered that like I had autism until, you know, the last couple of years when like my providers like mentioned it. But um, or when I asked about it, I think, and they agreed that they think that's the case. But yeah, as an adult, obviously you can't just like go get a diagnosis for autism.
Hmm.
That's another thing. It's not covered for adults. It's only covered for children. But if you are someone who wasn't diagnosed as a child due to the negligence of the system, they still won't cover it as an adult, even though there's services that like I kind of need and could really
Yeah.
use right now, that I, you know, I can't access. And then getting diagnosed is like $5,000.
I did hear
Yeah.
something about similar about that on TikTok. It was like someone was like, "Oh, please give me how
Yeah.
much money, like $5,000, because
Mm-hmm.
I need to get that autism like diagnosed." So
Yeah.
I actually read something about the fact that the brainstem issues,
Mm-hmm.
whatever is small damages or compression or whatever, that has a bigger chance to have autism.
Yeah. Yeah. Um, I think that our understanding around autism is like just starting to open up to what it maybe really will be.
Hmm.
Um, you know, understood as in maybe 20 or 30 years. But
So quite
it's a
far
big
away.
part of like, yeah, I think it's something that we don't have the full picture on. And I don't even like the fact that certain condition like brainstem like damage could lead to this. I think that might be the case.
Hmm.
It might be correlated with that, or it might even be causal. But like I'm not sure like the lens that I'm seeing it through is through like a non-pathologic lens right now as of recently. Like I feel like autism isn't necessarily the reason autism is a disability is because we're in a capitalist society. Let me put it that way. It wouldn't be disabling if we were, in a society that wasn't structured in such a way that like, makes us a commodity. Like we have to brand ourselves. We have to create a like when that started happening in this country, like I got very uncomfortable. I still don't like the idea that I have to brand myself or be like, I have to pick a phrase or like a name that will be my brand or like a mission, like they'll be my mission, like as a person, like that's something that you do for a business. And I think that some of this whole movement to like market yourself and brand yourself and everything is having like a weird impact that most things like have when we, like something starts, we don't always like foresee the downstream effects of like, phones or internet or anything, even anything. It's just like an advancement, right? But I think that some of the downstream effects of this like branding is like a sort of, it's making people one note, like I think it's going to make it even harder to see people as multidimensional beings that are, capable of change. Cause it's like, oh, well, what if, this was your mission before, and now based on this new information, you have like a new mission. In a way, I think it's like we're painting ourselves into boxes, into corners a little bit more. And I don't want to do that. Like I'm so averse to being constrained in that way that I don't even like it's like I don't know, I just have so many ideas and there's so many things that I've done in life at different stages where I thought that was the thing that defined me there or whatever. Like and I am someone who I can commit to something for a long time, but I don't. One thing I enjoy about where I am now is like being able to not identify as all the identities that I had. And like it is negative, like it was negative at first. It's hard, especially because I like just reached a milestone, of earning a degree I worked on for like a really long time. And yeah, and yet still it feels good to not have to be a veterinarian like in all circles and to have that be a primary identity of mine or to not even have like being smart as an identity of mine, like having these cognitive issues like get worse, like there are definitely, and I think just like the word smart and like intelligent, all of that is like difficult to pin down at the at the least. But
I see that like a lot of branding right now with people that like you said, putting the boxes, but we can literally to be anything we want, and it doesn't really have to be in a way like if you don't want to do any kind of medicine, humanitarian, and then you do something else, and then it's totally fine. Like it's no one should restrict you to do that, and or you can do both at the same time.
Yeah, I think that's what I'm trying to do. Just like zoom out and see all the things that maybe like used to be identities and things that I rediscovered, that a lot of things I stopped doing or I told myself I stopped liking because like I got symptomatic during it and there was never an explanation for that. And so I just said, well, I don't like it because I don't want to have to keep being asked to do it. Like shopping, going in the hot tub, going anywhere hot, going hiking. There's a lot that I gave up over the years. But,
I know recently, like this might be a little bit harder conversation into probably the deeper end, that I know that you will feel a little bit lost or feeling hopeless. I don't know what went on, but with whatever is going on with the medical system and the people that who wanted to just take the easy way out, and did it really affect your mental health in a sense, like recently with the diagnostics stuff and then like with seeking for more treatment, basically opinions?
Yeah.
The way that you don't believe yourself, like.
Yeah. I think that me not believing myself has definitely become less, but it still happens like maybe like once a day, but it's funny now. It's like kind of laughable. I have immediate evidence to the contrary. You know what I mean? It's not like, well, here I am like doing surgery, like clearly I'm still functioning, like it's not like back when I had more functionality and like could dress myself without help and things like that, it's like now like for me, what's been really hard with like hopelessness and is, well, it's been hard and it's also been helpful. Like, but basically like my will to live has like improved when I kind of like internalize the fact that the medical system that we're in, like, and the healthcare system overall, like, doesn't really want us to live. Like, it wants us to cave into the desire to, you know, exit the world. Like, I think that it's always been like it was helpful for me in like fighting harder to recover from what I thought was an eating disorder when I thought people were rooting against me. You know, I'm one of those people, I guess, who wants to like make people wrong. No, no, I just want to like, it makes me a little more motivated to have people think I can't do something, or even when I think I can't do something.
Yeah.
So yeah, I think that now the voice that's allowing me to like continue in those moments, that's one I didn't really have as strongly before, but it's like because, you know, the more evidence that I get that, you know, the systems that are supposed to be in place to serve us really aren't built to serve us. Like every time that, you know, I see another post of a friend of mine getting left by an Uber driver who has an accessible van and yet seems to not want to pick up you know, people who need that. But that happens. You know, one of my close friends in undergrad had a power chair, and like at the time I had no idea I was ever going to be part of the disabled community, or that I was at the time, right? But she yeah, was constantly encountering like issues because we were always trying to go out to the bars and stuff, right? So we would check where was accessible, but then like at the end of the night it was really hard to find rides. Like someone would have to stay with her and wait because like so many rides would not come. And you know, I think maybe the issues are a little better because back then it was cabs because Uber didn't exist yet or wasn't in Madison yet.
It's not
But
here in Texas, you know, accessible van.
wait, really?
No, like I mean, it's a huge amount of money to pay.
Like Uber isn't in Texas, or you mean they don't have accessible
no.
vans?
Like yeah, they do have Uber, they do have Lyft, but they don't have like accessible van.
Got it. Because like back then it was the cab companies, so we would just, you know, we'd call cabs, and they had an accessible line that you like one of the three cab companies in Madison. No, this is all I haven't thought about this in detail in a while, but like one of the three cab companies had accessible vans, but you know, being as there probably weren't very many of them, maybe there was like one or two or three, I don't know, but like it was always a really long wait to get them, and a lot of the time they just like didn't come. So yeah, I mean, moments are hopeless. Like there's definitely a lot of moments where I like um I don't feel like I have the strength to withstand the things that are most likely in my future. Like I don't have much hope anymore of like I mean before I had the overarching like EDS diagnosis and everything, every time I would have a medical issue come up, I thought I'll just get through this and then like hopefully I can just like not go to the doctor again until I'm 50, you know, or like not have to have anything major for a long time because I'm going to do all the things right and I'm going to make it better this time, right? I don't really have that anymore. And so in certain moments it's really hard to like think about the fact that I'm going to have to keep interacting with the healthcare system so much, and probably like more in a way. I mean, I hope to fix some of the major issues and like, you know, maybe buy myself a couple decades of like less healthcare exposure, but those are hopeless times. That's the thought that really gets me.
Yeah.
Well, is just thinking that like this is the best it will ever be kind of thing, that like it'll continue to get like my condition will continue to worsen a system that is ill-equipped to handle patients like us.
Yeah, I mean, at least you're quite close to the answer, right? And I know that
I hope so.
Yeah,
I've
really
felt that way before. You know, I think that it's also hard because a lot of these symptoms are vague and have a lot of possible explanations, many of which maybe do partially contribute all to the same issue. You know, like I know that I have food triggers, but I know that's not the only thing. And I know that like, you know, so I think MCAS is an element of it. And then like there's all these different issues that can all produce like almost identical symptoms. So for me, the head thing, like knowing that using the collar helps the symptoms, like that's helpful. That's a diagnostic in itself. And I think in human medicine, they don't use those types of diagnostics, empirical evidence, like as like when a treatment has low risk, you can use it as the diagnostic if response to the treatment proves your thing. You know, it's like a cheap and dirty diagnostic. If the treatment is like surgery, probably not, right? But like, sometimes you do an explore. So yeah.
Did someone actually give you the prescription for the customized collar? Yeah.
For this? Yeah. My pain management doctor did. And she helped me kind of get some more like therapies for the like pain and stuff that is associated with it. But I'm really really hopeful for a cure, like something that fixes an issue, that's big enough that either I can reduce my meds to like a couple or I can like come off of a lot of them,
Yeah.
Yeah.
I think that is really good. Like almost like wrapping up thoughts, because I'm glad that you still feel hope for actually finding the answers and then some good treatments. Hopefully that surgery isn't going to be the only options, and for you that conservative measures can also help a lot of these CCI symptoms, and sometimes can heal ligaments, and then you're able to get stronger and essentially really getting free from it, the whole thing. But I feel like it's just the whole entire journey to really even know that you have this instability issue instead of like psychological issue is really big difference.
Right. Yeah. Even this is like new and honestly has a lot to do with like you and like other people, like someone that I see in this area, who's in her 60s as a psychologist, like who has it as well, who's helped me kind of like navigate these common issues. She was able to recognize better than any of my doctors that, oh, those issues sound like CCI. Like, does it help when you turn your head down? And I was like, oh my God. Yeah. Like so much. And so for like a couple of weeks, I just had like a towel and I was like holding my head in a down position because it's very hard to remember to do that.
Yeah.
Like, like when you're doing other things. And then I would just find myself like about to pass out or having really bad pain. And I'm like, oh my God, why is it so bad? And I'd be like, oh yeah. And then I would just like rotate my head down or lay down and rotate it. And I was like, oh, like it makes it immediately a lot better. Like I can feel almost the way it feels when you're kneeling and your circulation is cut off and then you stand back up and you can feel the reperfusion.
Yeah.
I feel it. Yeah.
I think I'm recognizing it in the opposite way, like as that every time people like put me to the headrest and so you're slightly hyperextended and then I suddenly start like not fainting but unresponsive.
Yeah.
And that
happens. Yeah.
It is really scary because in responsive state is what happened with the brainstem literally having everything cut off, right?
Yeah.
And so you don't have that kind of signal going through. And so people need to
it's hard to communicate in those moments. Like that's what I've found is hard. Like I even had my hospitalist come in with the resident, like when I was admitted last time, and like find me. I had been left in a wheelchair by the transport guy and he didn't put me back in my bed. He just like left me there and I was already kind of passing out on the way back. So he like I don't really even like remember him leaving me there. I kind of do, but I know that my doctor came in and found me there in the chair, just like with my head, just like against my chest. Like I couldn't hold up. Right. And that's often how I pass out if I go out in I don't have my power chair yet. So that's what happens. And they didn't recognize that I was like in a not good position. Like they thought I was napping.
I think my neurosurgeon would be like freaked out at that position. Like if
yes, any doctor should, any human should. Like people don't nap that way. You know what I mean? Like people don't nap. Like if you find your mom against it, you'd be like, hey, can you, maybe let's find you a comfortable position. But instead they were like, he started trying to talk to me about something like, and like as if I was in a comfortable position. I remember hearing them and being like, hey, I need help. I was trying to communicate that I needed some fucking help. And apparently that didn't get across. And they just like, I remember him saying like, well, do you want us to just come back later so you can rest? And I couldn't say anything. And he was just like, okay, we'll come back later. And I remember trying to be like, please get a nurse, like help. And like, they didn't, they left and never came back. Nobody came back. I tried to crawl back to bed eventually. And someone came and found me on the floor. One of the physical therapists who was pregnant.
Yeah. I mean, especially like if you actually be successfully going to the bed, right? And then
Yeah,
later on, if you mention those whole thing, like they're like, well, but you're fine right now.
exactly. Like, because I mean, they came back in the room. Like once this physical therapist found me, then there's like six people in the room like immediately, and then they put me back on the bed, and then the doctors come in and act all concerned. And
Mm.
I do remember being mad, being like, what were you doing 10 minutes ago when you were in here? What was that? Like, what did you think I was doing? I really grilled them on it because they were like, well, I didn't know that was what you look like when you're pre-syncopal. Like, I didn't know that was what was happening. And I'm like, you should not let anyone ever nap like that. What are you talking about? Like
Yeah.
that, even if I was like just napping, that's bad for my neck, like anyone's neck.
Mhm. Well,
So,
you napped this way. I not napped, but fainted this way. I fainted the opposite way, 2 hours, and no one really come in. Even my
with
husband
your head
was next
back,
to me.
head
Yeah,
back. Oh, yeah.
yeah. That was right
Wow.
before I started having my right side of like spastic movement. They
Yeah.
call it
Spastic paralysis. Yeah.
they call it abnormal movement.
It's spastic paralysis is what it's called. There's like two types of paralysis when you get talking about loss of motor function. There's flaccid and there's spastic paralysis. It has to do with whether it's an upper or lower motor neuron issue. Tetanus is a good
Yeah.
example of spastic, and botulism is a good example of flaccid, and both come from clostridial diseases, clostridial bacteria. So,
Yeah.
yeah.
So with all these things that like how was the diagnostic tests performed in clinic without the neurologist? I'm kind of curious about it because
Yeah.
also I think this is a one thing that I wanted to ask everyone about.
Mm-hmm.
One is also raise awareness of like what exactly happening in the clinic that people are
Yeah.
clicking here, doing this there. But also the other
Yeah.
thing is like, do you feel like they are doing that accurately, everyone? Like more of
No.
a on the standard form of the
You mean like,
neurological
do I
tests?
feel like the neuro exam
Mm.
or like
Your
the
pretty
exam?
much your exam. So that shows like upper motor neuron signs and
Right,
like
right, right.
now we have so this is a big structure like right here.
Yeah.
We have imaging or testing like blood test, things like
Yeah.
that. It's measurable, right? And then or maybe still subjective with the
Right.
radiologist. But then we have also the signs and symptoms.
Right. Yeah.
And
So I've sorry, go ahead. Yeah.
no.
I think, are you asking about like how they like they are not very good at incorporating history or and like beyond that, because first that's an issue because any internal medicine field, which neurology comes off of internal medicine, same with like cardiology and rheumatology and everything, but um, they need to be impeccable history takers. The clinical interview is, what it was supposed to be called in human medicine, and they're supposed to be really good at doing that because that's a huge part of the picture. Surgically, like you're kind of working with what you have right there because you're going to physically go change it, but and you're more working with imaging and stuff, objective measures like that. But with internal medicine, like you are dealing with most of the information gathered is going to be from what people tell you. Um, like at least in vet med, because we don't get to run all of the tests we want to. And for some diseases, there's like some finding that proves it. It makes it like the highly most likely thing or whatever. But yeah, like there's definitely areas where the clinical interview and the history taking process is incredibly important. And I guess the point is I don't think neuro does a very good job of it. I think that the neurologists that I've seen when I've been inpatient, again, it has a very much a feeling of like wanting to get me off their desk, like they, kind of don't want to be here. They feel like my issues are really mild, or a lot of the times they say like, maybe this thing is caused by something else, like a medication. So let's wait for you to come off this. 'Cause a lot of my issues that I had were like, I mean, it's been a long decline, right? But like there was I was starting to have dysphagia and like choking a lot more. And then also having speech issues, like facial tics and like problems saying certain sounds and words. I'm usually a really fast talker. Like even the way I'm talking now is a lot slower than I used to talk because I don't want my face to just be like twitching out all the time, which it does if I try to talk at my normal pace now. So I made a lot of like changes to like the way I do some of that stuff, but all of that is really informed by the speech language pathologists that I've seen. You know,
Mm.
they do like so much more than I ever thought, first of all, but also like the neurologists that I saw, um, they've always kind of just been like, yeah, I don't know, like your changes are maybe really subtle, like I don't notice anything right now. And then there's certain elements of the exam that like I really feel should be standard that aren't, such as like the strength testing is
Mhm.
like incredibly unstandardized in a way that like is really intense. Like and it's not, it doesn't even always correlate with like someone's like their size or like, you know, their strength. It would seem it's kind of like, I feel like a lot of the time the neurologists don't test my strength very hard. Like they're like, here, like don't let me push, don't let me push, but they're like not pushing very hard, like at all.
Yeah.
It's almost like they have a problem. You know, I'm like, but it's more like they're not trying to detect something, you know what I mean?
Hmm.
It's like that same thing that I was saying with the tests, except these tests, because everything you do is a test, like even your clinical exam, it's supposed to help you rule in and out certain things, right?
Yeah.
And when they do that test and they are the one who gets to say the outcome, like, right, it's not an image, it's not a blood test. Like they're the one who gets to say if you have enough strength. So they get to just immediately, you know, pass you on that test so they don't have to deal with it. And it's subjective enough that like they could say they didn't. Like I've had people do those strength tests in the same day and get different numbers, like within hours of each other. So
Yeah. I mean, even the neurosurgeon, sometimes they look at you like, oh, you can still lift your arm like this. And they're like, oh, you still have two. I'm just like, huh? You know, I sort of like they almost like
yeah.
one of those followers that who just look at your video and say, oh yeah, she still have strength, she can move her
Oh,
arm.
right.
But
Yes.
yeah,
Yes.
but
People
I
can diagnose
particularly,
you.
yeah, but particularly really want to mention this, like, you
Yeah.
know, this is one of my idea of future videos, but like I definitely feel this is ridiculous. I don't have like a feather something, but this is how they do Huffman sign. They just went, oh yeah, you don't have any Huffman sign. That makes sense. So
What do they do?
they really do, they do it like super super light on your
Yeah.
fingertips, and
Uh-huh.
this isn't going to cause any reflux,
Uh,
abnormal reflux. So
right.
real one actually you had to plug hard, and every single time it works. It
Yeah.
will have the positive sign, but they don't.
Yeah. It's interesting that you say these things because it reminds me a lot of just the difference between like me trying to do a neuro exam on a German Shepherd, right? And a neurologist trying to do a neuro exam on a German Shepherd, or even a surgeon or orthopedic surgeon. Because a lot of the time with ortho, they have to, because the dog can't tell us I'm limping on it because it's in pain versus I'm limping on it because I can't feel, or I'm not weight bearing because I can't feel, right? So we have to suss out those issues a lot more than
Mhm.
in human medicine or from like further back. And uh, like I'm just not strong enough to do a good neuro exam on a large dog. And I've known that since I became a vet. Um, but because of that, like when I was trying to learn certain signs like that, like there's different, you know, we have different ones for like dogs and cats and horses and everything. But yeah, some of them, like I can't do them. I had to find like modifications or maybe a different way to interrogate that same system.
Mhm.
Because like it just wasn't going to be like uh the biggest one I think of. Like dogs tear their ACL all the time. We call it a different cranial cruciate ligament, but there's a certain it's called cranial drawer when you try to like move the tibia relative to the femur to see if there's laxity, or this shouldn't be able to do that.
Yeah.
I'm not like strong enough to grip those two areas of the bone and to like manipulate them. It's not a good I'm not going to be accurate using that test, right? So like I have to use a different one called tibial thrust, which a lot of other people find harder because you're not holding both bones. But in any case, it's, you know, there's things like that that you kind of have to standardize for yourself throughout
Mhm.
the like your journey of becoming a clinician. Like
Yeah.
um and it seems like that, and like what you're saying where that's like an error, like a rookie error, what you're talking about with the finger, like not knowing which tests are supposed to be like a strong response and which are supposed to be less, and like how much effort you have to put in to elicit that response. Like I've had that even with getting like just the reflex on the knee for dogs. Like it's just kind of getting a feel for it kind of thing. But that strikes me as like the person doesn't have a feel for it, or they know they're missing it and they want to miss it so that they don't have to do the work.
Mhm.
Either way, it sucks.
Well, that makes
Either way, it's
me
a
really
problem
wonder.
that needs to be
Yeah,
addressed.
yeah, that makes me really wonder. The one that triggered me so much, like, sorry, triggered me the most at the time when
Mhm.
I was about to leave, like to LA and just enjoy a weekend. But what happened is that the doctor literally just did like with, I don't know if you know, like dog, cats has that, but ankle dorsal reflex that you go up or that there's a
Oh yeah.
clonus.
Hmm.
There's actually from the OT. From the OT, I was working with for like orthotics, and then he was
Hmm.
the one telling me, no, there is R1 and R2, and he must did R1, and that's why you will have slowly start the clonus instead of the just jerky sudden starting of clonus. But they
Huh.
just did that, and then they said, oh, because it slowly start, this is clinically proven to be functional.
Wait, he said because it starts slowly and
Yes.
doesn't start abruptly, that it's not clonic, because that's not true. Some seizures do start slowly. I've definitely seen that in patients with my eyes that I have then gone
Yeah.
and given like an anti-seizure medication to and stopped the seizure. So I know it was seizure.
Yeah. But
Like I've
they
seen
said
it. That's
they said
crazy.
they said it's not. They said that's why it's functional. And I was like, it took me about five
Yeah.
hours
The
just
number of times, like, yeah,
yeah.
the number of times I've been told that I'm not dehydrated because my kidney values are normal, it makes me sick. It's so upsetting because like that means that you're waiting, because when you start to have abnormal creatinine, that means
Mhm.
75% of your nephrons are not functioning anymore. Okay.
Mm.
That's when it starts to creep outside the normal value. It will not go outside of the normal reference range before 75% of the nephrons are not working.
Wow.
So like, yeah, like, and that's AKI, which I've had twice now, but um but like I've been dehydrated and hypovolemic many, many times outside of those times, where like, and some of those times, maybe at least half, like they were trying to use the fact that my creat was normal as evidence that I was not dehydrated and did not require fluids.
Wow.
There's some doctors, like, another thing I observe is that it seems like doctors who are not trained in the US or who that like
Mhm.
at least did med school abroad or something, like they had a lot of life experience
Mhm.
and like medical experience abroad, and especially in countries that are not as developed as ours, like
Yeah.
they tend to be better doctors because they tend to have worked with less. They have to use more clinical reasoning, and like it's less about remembering things because there's no illusions in those places that you can know everything, and you don't get to run all those tests like that you might want to.
Yeah.
So I have like found that I started noticing when I would go, because I would go to the ER for like the same issues, right? Like usually GI issues, GI losses, and fainting, and that type of thing.
Mhm.
And some of the doctors would look at my tongue. I don't know if they've done this to you, but it's kind of more of like an Eastern thing, like hailing from TCM, from traditional Chinese medicine, where
Yeah.
it's like they look at your tongue to get different characteristics about the like state of that patient. And because I looked into it after a couple of like doctors who had been foreign and not from China either, like different places, not in the Western country, not Western countries though. They like would do that more often. I don't think I've had any like state like US trained doctors do that, but those doctors would say that I was dehydrated and they would put me on fluids, and they would use that as as one of their objective measures, because I mean, I'd imagine it's because they've seen probably a lot more severely like dehydrated patients than people see here, and they've seen that how long your creat will
Yeah.
hold out for, which varying patient to patient, but a long time, like a long time.
Mhm.
75%, it's like same with the
Yeah.
heart. It compensates till it can't. Like it like literally it will compensate and it will look completely normal on EKG or whatever until it can't.
Wow.
Um, so it is frustrating that our system is so reactive when we have the data and evidence to know that there is a way to be proactive.
Yeah.
They're going to wait for kidneys to fail.
We definitely not set up for the chronic phase or anything that it's just
Yeah.
like not in the emergency, especially in the ER situation. that either you're about to die
Right.
and you're gonna do something about it. Um,
Hmm.
yeah, it's very, very, very disheartening for sure. And
Well, even if you are about to die, if you're not about to die in a way that they can detect, then it still doesn't matter, and they're going to send you home.
yeah,
Yeah. So that's the
or that
hard part. It's not about whether you're really about to die. It's about if they believe you, or they can, if you come up positive on one of the things that they can service you for. You know what I mean? Like it's
yeah,
like, well, do you have a coronary? No. So okay, well then I don't know what to do with your heart. Like it's not. It must not be an emergency, because that's
yeah.
the only type
Well,
of emergency that could ever happen for a heart.
that's funny because
You know, there's
this
like
is
three things, and they're like, if it's not one of those,
no, you don't have anything going on. So then they will seek for psych reason,
right?
right? But then they're not really trained for
Yeah. Yep.
internets. Yeah, I trying to see where is the change going to be, like, for exactly the system. It's just so difficult because of the problem,
Yeah.
the entire structure. And so looking back everything,
Yeah.
you know, I'm really glad that we have you here because I think that you also have a perspective of treating animals and seeing that how this is so not humanizing, like with our patients, and we are human,
Yeah.
and they don't treat the
Right.
same, they
Yeah.
they don't treat it objectively. They don't really have really standard testing and stuff. And then so there's
Yeah.
just a lot of things that are lacking in like a charting system as well. There's just so
Yeah.
much. And
Yeah. Yeah. It stems from the unknown, and as vets, we're masters of that, because there's never an illusion that like the thing you learn to do in vet school is how to obtain information that is accurate, most likely to be accurate, like, and how to get that. Like you're not, because we're not going to be seeing the same diseases in 20 or 30 years that we're seeing right now as the most prevalent, so
yeah,
it's not about memorizing all these different illnesses, on this rotation. It's about learning how to get a complete data set and learning how to think clinically and figure out, what's going on with what you have at your disposal.
you said
So
something about
I
analytical
do think
thinking.
human medicine has a lot to learn from that.
Yeah.
Yeah. It definitely takes some analytical thinking to be a good doctor, like a clinician. Like you have to be able to think about things that aren't currently something we are aware of. Like, so yeah, I mean, I think that the issue, like, so I have one, person that one connection who's an MD and a JD, who had mentioned that it seems that there are a lot more analytical thinkers in law than in medicine. And that most people who are in medicine, at least that go to med school in the States, like they are very good at rote memorization of like a list of things that they can then regurgitate and apply to only that one situation. But they're not as skilled at being able to look, like to zoom out and look at a large, picture and connect dots that maybe don't have an established connection between them yet. Like you have to be able to rely on your theoretical like framework, your basis of knowledge and physiology to look at something and say, like this isn't, adding up. And then even if there isn't like a described condition, describe it, like describe what you're seeing. That's always the thing. It's like, that's why you don't just say normal, like describe it, like at least just describe it, like normal rate and rhythm, no murmurs heard. Like, it's not that hard to describe normal a little bit better. So, I think that's one thing that's like was helpful. I didn't realize is my therapist like offered to she happens to like also have similar conditions and have worked through a lot of these systems. I never would have thought to ask, but she said that for some patients, and she offered for me, she would like call our doctors and to weigh in and let them know that she's evaluated us psychologically and like doesn't think it's definitely not psych. I would never have thought to ask a psych provider to do that. All these years of psych treatment, I think just because I assumed it was a psych problem, I didn't think to ask them to testify that it wasn't. But like now, that's something that probably would be helpful for people to know, that they can like ask that. Because it's like if your doctor keeps saying it's anxiety, have them talk to the person who's the expert on that, on you with your specific issues.
Mm-hmm.
So
I
like
think that's a great
that was
suggestion.
helpful.
Right? Yeah, definitely for sure. Well,
Yeah.
yeah, it's
Because
such a
they do
long,
know. And I was like, when you're saying, where's the change coming from? Yeah.
yeah.
I was thinking maybe there. But
Yeah, there's a long list of like, what we want to change, but I think that's a great idea
yeah.
to really have brought on the other specialties into the picture. So, like the
Yeah.
multidiscipline system, that's kind of
Yeah.
like the core of the issue is that there is no collaboration between the doctors, and we are the one that
Yes.
who's in charge of collaborating everyone together, but it's just so difficult.
Right. Yeah. Sending your records, unfortunately, isn't enough. They'll still like show up to the appointment and be like, what are you here for?
Yeah,
You know?
yeah,
So it's, yeah. And it's like they talk about multidisciplinary, but like, they'll say, well, I think this is just anxiety. And when you say, well, I was just at my psychiatrist yesterday and she said, I need to see you. They don't have a comeback. Like it's weird, at least sometimes. Because that just happened to me recently. I luckily had just seen her like literally the day before. And so I was like, well, I can reassure you that she is in agreement. These are not issues that are in her wheelhouse and that they are not psychological in origin,
yeah.
you know?
It's like your psych
But
doctors are defending for
yeah,
you, and then the other one just like, oh, I don't have a degree, but I would rather think that this is. It's just so unreasonable, but
right.
yeah,
Yeah.
I'm hoping that
Yeah.
it's
But
gonna
it's, at
eventually
least we're
come
talking
to a
about it and that's
place.
the only way it'll get better.
Yeah, definitely. I think this is a very helpful discussion. I think every single story matters. That's always,
Yes.
there's more story to be told, and there's more people feel related, and there's less people
Yeah.
get gaslighted and then feel disbelief of themselves. I think that's the worst thing that can happen with any people
Yeah.
who have occult conditions, because
Absolutely.
like I actually mentioned that a cult that has another different meaning in Western
Hmm.
culture, especially like,
Yeah.
with the more of a UK type of a colony. So like they
Hmm.
often will have this idea of witchcraft. And I don't know who I
Yes.
said I really, really have to dig and do research about exactly when this occult term into the medical field. Because right now, at least I
Yeah.
would say there's so many different states, that are not accepting occult this word at all. So if you do surgery, you go back.
Oh, interesting.
Hmm. Yeah, that's what happened to me. So like I have a cotillo
Okay.
cord, so you don't see it on
Right.
imaging. But they
Yeah.
open up, they say, oh, it is tetracord because it's tight. And then they write in the surgical notes, they did everything. And then I got the surgery. And then a year later, I had to beg to put on a back surgery and still don't have a date on it. For what? Like, that's why it makes, that's why it made the entire testing difficult. There was literally
Yeah.
testing showing seminal accessory evoke potential that my lower waist down has some issues.
Yeah.
So that means
Right.
like there's some kind of tears that cause like there's no signal going down. But
Right.
their reason is that, oh, we checked that imaging is normal, and then like maybe she just have like hereditary spastic paraplegia. I was like, where's that come from? I do have a tetracord.
Yeah.
You don't see that on my chart?
Sometimes
No,
they
you
reach
don't.
so far that like for
Hmm.
things that are harder to fathom, but usually it's things that don't have a treatment or that don't have like that it's like they don't have to do anything else now
Mm.
conveniently.
But better not doing
Yeah.
surgery than doing surgery, right? So, I mean, I understand that's a good
Yeah.
thing that if we don't need to do surgery, but
Yeah.
that's another problem. If there is a problem existed, do you believe the patient's symptom signs or just their imaging? You know?
Yeah, I mean, I think that a good doctor believes their science 100%. Like, I don't think that it's, I mean, and I always just take it back to my own framework as a veterinarian. And it's like, so, and, so for, we have for the verbal component is the client. So it's kind of like the veterinary client patient relationship is what it's called instead of just the patient doctor relationship or whatever. But
Mm-hmm.
it's, sometimes, yeah, like, I mean, that happens all the time. Like tests come back normal. And it's the question is, I was just talking about this with my friend who's in her first year, that it like when physicians tend to like deliver news that is normal as like as if that is a solution, the normal test result. You know what I mean? Like someone came into you for a problem, and most people don't seek medical attention for like something that, you know, they just want peace of mind, but it's probably not an issue, you know, especially now, like with the access to healthcare being what it is.
Hmm.
People are not going in unless there's like a real problem. Like they don't just want you to put their mind at ease. So it's not about putting my mind at ease. Like it's not about me being happy that the test is normal, but that is the reaction I had for like at least a decade because they condition you to, they're like, I have great news, and like they, you know, they make it seem like they're doing something positive for you by not helping you, and
Yeah.
by leaving you in the same place that you were, only now with
Mm.
testing that shows you don't have a problem, so kind of worse position, right? Because now you can't really get help from it as easily, for it as easily. So like um i I think that like the yeah the when we communicate results, I think the biggest thing that went into me learning how to write medical records is that when I do a test, like you have to know what you're going to do with that information. Like that's almost as important as like knowing why to order the test. Like why, because like you need to know what are the possible outcomes, what do they mean, um you know, and then what do I do if it's a positive, what do I do next if it's a negative. Like that's part of
Mm.
my algorithm of deciding what testing I'm going to do, and what makes the most sense, because like most of the time clients don't just have infinite money, so you kind of have to figure out, like a lot of the time there's many tests you can do for a set of signs that may rule in or out certain conditions, so it's like a very complex kind of process. Um but like you're never like I never deliver that like normal news and then not have anything else planned. Like it's very odd how they're able to just do that to us and get away with it in like most cases. They like do a little kind of mind game where they make you think that it's the I have good news thing. And they're like, you should be happy. You should be, it's nothing bad. Like you should be glad this test for everything bad. You know, I had a cardiologist tell me once on a Holter study that like it was nothing bad. That like, yeah, my heart rate went up to in the 180s and there was like a 2-second pause after an atrial run, but that there was nothing bad. And I think that
But
what
can
he's
you
saying is
explain it?
like there's no, yeah, I think what he's saying is there's nothing that he was like, this was an older physician too, but it doesn't really, I think it's, there's certain things that they think of as like the things they know of as being bad, you know, like
Mm. Yeah.
as being
Boxes.
life threatening, I guess would be the thing. Like, for example, VTAC is a really bad rhythm. I've had that rhythm before, but it's only shortly. Like, it's not, so that's a shockable rhythm that can
Mm.
lead to like, if you get to pulseless VTAC, then you're in a code. But um, like that's I think what he's saying is like it's not one of these known things that's really bad, but like they don't entertain the fact that like they're seeing objective evidence of, you know, something going wrong with like the heart shouldn't be that fast. Yeah, they can acknowledge that,
Yeah.
but then like they don't
But then they
take it a
see
step further to
the
say, well, that means that something's causing this to be abnormal that isn't part of the things we've tested for, therefore we have to do further testing.
yeah.
Like that seems to be a step they just like don't get to, but that is very much part of a thorough diagnostic workup because yeah,
I
the
think
signs are coming from somewhere. So as a good doctor, you always believe the signs. Sometimes testing, like there's some diseases that testing, like even known diseases that have very poor ability to test for, like FIP, the feline disease, for which they put, it's a feline coronavirus, and so they pulled the drug remdesivir came off of feline trials for FIP. And actually, we only just recently got the approval to use it in cats because during that time it was pulled from clinical trials, and therefore we weren't able to use this drug that we'd been working on to cure this previously 100% fatal disease in cats. So that's
mm,
been frustrating. But um,
what we connected what you just said before, which means like they're really good
yeah,
at memorization. They're good at memory all these
yes,
boxes, but the test didn't fit in the box.
right.
So that's a good thing because it's
So they
not
just,
those theories,
yeah,
the things, but they don't know the unknowns. So then they will be putting
right.
back to the patients as that's a good news. So you shouldn't really have these
Mm-hmm.
signs or symptoms.
Right. And I think the really big problem with that is that um, because they don't have to do it that way. Like they could have the test come back normally and be like, so the test came back normal, and like, because the way I go over results that are normal in a face of still being disease present is like, so we ran this test and it came back. I might go over what it tests for to remind them and be like, this came back normal limits. Sometimes it's a situation where it's like we can track it over time and potentially like, we'll see a trend, or sometimes there's another test to go do next. But I always have that ready.
Yeah.
It's like, okay, this has had that, positive, and like, while that's or negative, so while that's a good thing, like it's I know that doesn't get you any closer to like finding a solution. So here's some next steps that we can take. It's weird that they just don't have that. They just get to skip that conversation for us, for people. They just think that. I think it's because like it like they think, therefore I don't know if they think that means you don't have a problem, or quite where that comes from, because like we don't I don't know, it's just like
is if patient feels like they're not believed, because I mean, in a sense that I almost feel like, well, I don't think really you have a problem, but like you can always come back, or like they're not really looking into or giving you at least another explanation of like, oh, this is negative for most of the known causes, right? But like the theory known causes, but like there's still unknown stuff that we didn't really know. We can test further, and then it is possible to be rare situation. But instead, they kind of feel like, rather than taking that route and saying that something is like we talked about the whole time, is really about this occult thing, right? You don't see things, or you don't see on test, and instead they're thinking, well, you must be the other way around, just like you manifested the symptoms, mind body thing, like then they start explaining to themselves, and they feel like it really makes sense.
Yeah, and that's, I think, why it's important to mention that a lot of these symptoms are really vague and like are not something to lean on for like you can't, like, for example, nausea, right? Like that can't, you can't say, oh, well, like, as you know, because I had a doctor recently say this actually, as you know, nausea is a symptom commonly associated with POTS. So your doctors found in this visit that all of your pain and that all of the pain and like symptoms were coming from POTS, so like there's, well, first of all, pain isn't really like a legit thing to say about POTS, but that is what they said, that my pain was caused by POTS in that visit that I complained about. But well, like there are a lot of symptoms that can be caused by a lot of different diseases, and in vet school we're taught to think of those as the vague symptoms that aren't like usually the ones that make or break any diagnosis. It's supposed to be that you see a patient, you do your exam, you work through a list of differential diagnoses. So you write down everything you can think of that might, have a patient like this, like, after you've done your history and your physical and maybe some tests or whatever, maybe you're just reviewing records, but you write down a bunch of stuff that might fit. And then you work through, like, so then like there's some diagnostics that'll exclude or rule in or out certain things. So maybe, that's how you approach it. And then you're kind of just crossing things off or circling things as you go along. It can get difficult for us sometimes if we have a positive for something that either doesn't mean what we think it means, or like two things can be true as well. You know what I mean? Sometimes you have two issues that summate to cause one syndrome, and you fix one, and then like the patient doesn't do well because you didn't fix both. Like like the most common one I think of is like hyperthyroidism in cats, which often masks kidney disease. So you might have a cat that you run blood on and its thyroid levels are really high, but its kidney values are okay. Well, I mean, we know that we need to recheck that cat, and after we control the thyroid, because that will make the kidney disease present on blood work if it is there. So there's a lot of little things like that I've had to learn about medicine, that it's really insulting that physicians don't have to learn about their single species and single area of specialty. Because I've had to learn how to apply that logic to like at least 4 different species, at the drop of a hat, and then like other ones that, we add into our realm of specialty. But yeah.
Yeah,
And
it's
I
so
have like a
much
disease that affects my
complex.
brain function, you know? So it's
Yeah,
like, it's just super
but
insulting
still,
that they can't like do that for us. Hard.
oh, a little unstable. Okay.
Sorry, can you hear me?
Okay. Yeah. Yeah, I know. They you said
Sorry,
they couldn't do it
but
for
yeah,
us.
I don't know. Sorry, I get
No, it's
excited.
okay. No, it's your
Yeah, it
internet
frustrates
get
me they can't
excited.
like do that same thing for us, you know?
Yeah. But this is really, really upsetting too. Like, I mean,
Yeah.
even you have brain function issues, you're still brilliant with all the different species of
Yeah, it
animals
is.
and how to treat and everything. Like those are so much more. And then like if we can treat animals like with compassion, why don't we
Yeah.
do that same to the human beings, you know, with
Yeah.
exactly same species.
Yeah.
So it's really great to, you know, having this conversation with you because I think that gives us another perspective, not
Yeah.
just from the patient, but also from, you know, a doctor perspective, that a physician perspective for be
Different
done.
patient population. Yeah.
Yeah, yeah,
Yeah.
that's good.
Yeah.
So yeah, I just
Right.
can't believe
Because it's
like
still medicine, but yeah.
exactly
Sorry.
same. Yes. So I really hope like especially the end of our key points that you pointed out with differential diagnosis and then you know collaboration with doctors and those like you know when tests were
Yeah.
normal that how we actually approach to it and those things that
Right.
is measurable that we can change but um yeah that's why we have this podcast for right and so we can
Yeah.
actually bring
And
this one to the table.
yeah. No, I hope there's more that come out like it. Like if I have more energy, I will like if I get my things like on a better route, you know, like I will try to I want to do something like that, but I think it just like I don't really like being on camera, but I do feel very passionately that these issues be addressed, and I think it's in the best interest of um like our species as a whole to talk about these things. Because everyone's going to become disabled at some point unless you die suddenly. I think people don't like to think about that, but you know,
Yeah, it's
like it's going to
scary.
happen unless like it's a complete surprise. Yeah.
Hmm. Yeah, that's so
So
true and
yeah,
it's it's a really important topic and I think that we really have to see each other hear each other and especially for physicians to hear us and hear the symptoms and sometimes getting dismissed so
yeah,
much that
right,
you know we don't feel like we have a voice so that's why I have this platform for
right,
us to really having a voice in seeking accurate diagnosis and having the incredible strength of those navigating those challenges. I'm very thankful for you to today to join, giving people more awareness about this occult conditions and any
hmm,
people with complex medical conditions. And don't forget to
yeah,
visit our website now at the thrivextribe.com/occult awareness and to access resources, read more about our topics, and support our mission. And if you found this episode enlightening, please consider subscribing to our podcast and really giving a great review and feedbacks to us is really important from more listeners and follow us also on social media at Occult Awareness to stay connected and informed about our upcoming episodes. And remember, your story matters and your health matters. And you're not alone in this journey. So until next time, keep striving for knowledge and awareness. Bye for now.